everyone. Thanks for everyone for joining. I have a lot to cover. So I'm Dr. Dani Cabral. For those who don't know me, I'm a board-certified neurologist and psychiatrist, an Alzheimer's specialist, physician, and clinical researcher here in Phoenix. And wanted to provide some easy to understand information about this new class of drugs, these anti-amyloid therapies. There's a lot of confusion about them, and I'd say especially with healthcare providers, I found that people tend to have strong opinions either for or against these medications. But most people haven't actually met anyone who's been on them. So it's interesting to see where these opinions are coming from. And what I've learned and heard from a lot of patients and families who are interested in learning more is that their healthcare providers, so say they have a family member with Alzheimer's disease that may be eligible, their healthcare providers aren't bringing up this conversation. They're not proposing this as an option. And so it's really essential that patients and families advocate. And it may turn out that at the beginning, for the next year at least or more, that it's really going to be the patients and families who are initiating the conversations and helping educate their healthcare providers about these things and getting them to be more comfortable. So I'm going to share my screen here. So my business is called Brain Love. So you're aware, there's the website, mybrainlove.com. I'm starting later this year a holistic private practice focused on these kinds of diseases for patients and families. So check that out and subscribe to the email list. The full website will be active in a couple weeks. Feel free to email me at any time with any questions. And then we have the YouTube channel and Facebook community. All right, so important disclosures relevant to this conversation. I was the principal investigator for the phase 3 trials of both of the drugs that have been approved in this class for Lecanemab and Donanemab. And also I was for another similar drug called Aducanumab that is no longer available. And I'm continue to be a consultant for Eisai and Eli Lilly, who are the makers of these medications. Now, today, in short, I want to cover what are these new treatments, who might be eligible, and what are pros, cons, and key considerations for you and your loved ones and your patients and families. So the really broad overview, big picture, is that up until these medications have been approved, there were no medications for Alzheimer's disease that targeted the biology of the disease. They were for the symptoms. So these medications that we're thinking of, the symptomatic treatments, are things like cholinesterase inhibitors, so donepezil, rivastigmine, galantamine, and then memantine. And so this is a whole new world we're living in right now with these new drugs that have been approved, these anti-amyloid drugs. And the point is, we don't have a cure. These aren't a cure. And these drugs aim to significantly slow the progression of the cognitive and functional decline in concert with decreasing the toxic pathology that's in the brain. Now, these are specifically anti-amyloid monoclonal antibody medications. So I'm going to give a brief overview about amyloid. Now, Dr. Alzheimer, pictured there, the first patient that he identified, so he was a psychiatrist and had some pathology experience looking at human specimens under a microscope. So he was caring for this woman, Auguste Dieter. She was quite young. She started having symptoms in her early 50s and progressed pretty quickly and had a significant amount of behavioral changes, psychosis, which is how he met her in an inpatient psychiatric unit. But he found her very interesting because she would make frequent comments about her memory trouble. And so this was a little different than other patients. So he continued to follow her. And upon death, he received approval from her husband to look at her brain under autopsy. And there he saw these atypical findings, which are now called amyloid plaques and tau tangles. And so you can see those amyloid plaques there. So this has become to be one of the amyloid and the tau, neuropathologic hallmarks of Alzheimer's disease, and essential to have these changes developing in one's brain to have the diagnosis of Alzheimer's disease. Now, I thought it would be helpful just to go a little bit in depth on what we know about amyloid. So we're all producing amyloid in our brains throughout our lives. That is normal, and it gets cleared. Now, something goes awry in some of us, and specifically as we age, is a risk factor. Where if you look at this image here, so APP is where it starts, the amyloid precursor protein, and so that gets cleaved into monomers and then forms into dimers, and these are soluble forms of amyloid, but something causes these to become insoluble and moving into oligomers, protofibrils, fibrils, and then the amyloid plaques. And so as they're moving into insoluble, they're becoming more toxic to the brain in different ways, indirectly and directly, disrupting the neurons and the connections between them, the synapses, which then ultimately has downstream effects that we're not sure exactly why tau develops and then works together with the tau tangles to damage and kill the brain cells and many other aspects of the brain. So we know that amyloid, we've learned that amyloid starts building up. It seems to be the first neuropathologic finding in Alzheimer's disease up to 20 years or maybe more before there's any symptoms. So that's been a clear target for treatments. Now, you may have heard about controversies with whether or not amyloid does play such a crucial role and whether that's what we should be targeting. And some of the reasons for this are that there are people who have a buildup of amyloid plaques, and the amount of amyloid plaques, so say it's severe, it doesn't correlate necessarily with clinical symptoms. So you could have two people with the same degree of clinical symptoms, so say mild dementia level of symptoms, but one person has a profound amount of amyloid plaques and another one just has slightly over the threshold for normal. Another reason there's controversy is that many humans show sometimes abundant amyloid deposits at death when looking at their brains at autopsy, but they weren't symptomatic. They didn't have any cognitive changes. And then we've seen with a number of these trials of these kinds of drugs that people have inconsistent benefits from the anti-amyloid drugs. Some benefit more than others, and we're still learning which groups benefit more or less. So this, I think it's helpful for us all to know, and hopefully most people who are savvy about their health and interested in this topic now know that this amyloid does start building up 20 years before any symptoms. And so this is just, I'll orient you here. So the x-axis is the clinical symptom onset, changes over time going from normal to dementia on the right side, and then the y-axis, the vertical, is the change in the biomarker. So this is looking at the different biological markers of Alzheimer's disease and how they change over time in conjunction with the symptoms starting up. And so you can see that starting at 20 years before symptoms, you can find in the cerebrospinal fluid and amyloid PET scan now, you can see these changes. And it ramps up pretty quickly. The slope increases quickly before any symptoms start. And then once we're hitting symptom onset or that mild cognitive impairment, amyloid levels pretty much are up and they are plateaued. The green is tau. So you see that building up, aggregating closer to the timing of symptoms. And that also has that sharp slope during these asymptomatic phases before any symptoms occur. So this is a huge area, huge opportunity here in the asymptomatic space, but we're talking about the symptomatic for the purposes of this talk, because that's what was studied with these drugs and approved. So what have we done over the years looking at targeting amyloid in our clinical trials? So this class of drugs has been studied for many years, probably over 20 years, including with animal models at the beginning and then moving into human clinical trials. And so I say that not to be discouraging, but to say we've really looked at a lot of different forms of these drugs targeting different places along the amyloid cascade in different types of populations and with different doses. And anyone who's familiar with clinical trials knows that what is crucial is finding the right patient at the right time with the right dose. And whenever you're starting a treatment in trial, we tend to start at a lower dose, and it's often subtherapeutic. It's too low to actually affect the disease, the pathology, in the biology. And so that's often why trials fail. And it's not because the drug doesn't work, it's that the dose is too low. And that's one reason why some of these in this table at the bottom, discontinued or not approved, likely failed. And then if we look at the table at the top, approved or in late development, so there's aducanumab, lecanemab, and donanemab. And so I will talk about lecanemab and donanemab, which those are the ones that are available now on the market. Aducanumab is no longer available, and remternetug is under investigation in a phase 3 trial and looks promising. So I showed you that amyloid cascade hypothesis, and here's where these different drugs target along the cascade. So they're in the same class, but they're different in terms of their specific targets. And we've learned some about what these different forms of amyloid do and their toxicity levels, but we still have a lot to learn. The first drug that was approved, aducanumab or Aduhelm, to great controversy, appropriately so, and I'm not going to go into the full detail, but essentially There were 2 phase 3 trials that were done by Biogen for this drug, and one was positive and one was negative. And because of the positive trial, they decided to pursue the FDA approval. And surprisingly, they received it, but then Medicare restricted coverage and access. And ultimately, it was not prescribable because it wasn't getting covered. And so it's no longer marketed. However, Lecanemab or Leqembi, that was approved in July of 2023 with full approval. And then Donanemab or Kisunla in July of 2024. So both of those are available and on the market specifically for early symptomatic Alzheimer's disease, which is mild cognitive impairment or mild dementia. And briefly, I'm not going to go too in depth on these, but the findings for both Lecanemab or Leqembi, the phase 3 trial, so that was over 1,700 participants around the world. And the big finding, the primary outcome here on the right, and what you see is that they were looking at the primary outcome was a clinical outcome. And so they were looking at the cognitive and functional changes over time with a composite called the Clinical Dementia Rating Sum of Boxes, or CDR Sum of Boxes, which is a commonly used measure in Alzheimer's trials. And so over the 18 months of treatment, you can see in that graph, the Lecanemab was the yellow and the blue was the placebo. 27% slowing of decline for those on drug compared to placebo at 18 months. And that was significant. And then all other secondary endpoints were significant. There was a number of measures. A key secondary endpoint was looking at the amyloid reduction, because of course an anti-amyloid drug is targeting the amyloid. You want to see the levels of amyloid clear out. And it's very effective at clearing out the amyloid. Even as early as 3 months into treatment, you could see the amyloid levels of those on the drug versus placebo were significantly different, where the ones on placebo, the amyloid levels, of course, stayed the same or slightly increased over the 18 months, whereas those on drugs dropped precipitously, and most normalized by 6 months, and then by 12 months, the most of them, the remainder. So there were also some exploratory endpoints of quality of life and caregiver burden, which of course that's so important. And sometimes you wish these were not just exploratory, but those were all positive too, that showed that those on the active drug on Lecanemab were better than those did better than those on the placebo. Now, adverse events. So this is a huge important areas, the safety and tolerability of these drugs. I'll talk more in depth on what these are, but we have infusion-related reactions. You can see drug versus placebo there. And then there's the ARIA-E and ARIA-H. So this is the most concerning side effect that can happen, and one that maybe you've heard about or know something about. This has to do with when these drugs effectively remove the amyloid from the brain, it can cause fluid shifts or bleeding. And these are the rates you can see here of drug versus placebo for the edema, or edema or effusion. So that's the fluid shift, and the H is hemorrhage or hemosiderin. So that's the blood. So certainly increased in the drug group versus the placebo. Now, these trials have been going on a long time. And so we have now what we call open label extension data, where after the 18 months of the treatment phase where half got drug, half got placebo, everyone was able to get the active drug. And so this is meaningful because what we can see here is that the people in the green were the ones that always were on the active drug. And the core is just the treatment phase, the 18 months. And then the OLE is the open label extension when everyone got the drug. And so you can see in the, this is the CDR sum of boxes, the change over time. So people keep declining, right? This isn't a cure, but it's slowing the decline. And the black is the placebo group that then becomes green because they get on the drug. And then the comparison group that they're showing here. So how do we know that that's really helpful to the placebo group at that point? Because you figure they've been continuing to progress, and so they're farther along in their disease. They have more disease burden in their brain, maybe more symptoms at that 18 months when they start. Well, the way they looked at it here was compared to a group that's matched somewhat, called, it's a large observational study called the Alzheimer's Disease Neuroimaging Initiative. And so this would be the natural history of someone, this pink line of someone who didn't ever, just is in the world, has Alzheimer's, biologically confirmed, but doesn't take any of these drugs. And so you can see they have more of a decline in their cognition and function over that 36 months compared to either group that got the drug. So after 3 years of lecanemab treatment, 59% of these patients showed improvement or no decline, interestingly, and 51% showed improvement from baseline on the CDR sum of boxes. Now, Donanemab, the other drug, or Kisunla, had somewhat similar findings. So their primary endpoint was a different composite of cognition and function called the IDRIS. And something unique that Lilly did with this Trailblazer studies is that they stratified people by low to medium tau versus everyone altogether, the combined population. So at the beginning, I mentioned how Dr. Alzheimer saw these amyloid plaques and tau tangles, basically, which they weren't called that at the time. And tau is such a crucial neuropathologic change that happens closer to symptom onset and does correspond closer to the severity of the symptoms. So it seems that basically if you have elevated amyloid, but your tau is still low, you have earlier on in the disease progression biologically, you have less disease burden in your brain. And so what they found is that those people who were earlier on benefited more in this trial over 18 months than the general population that included people who had also high tau. So they would be considered farther along in their disease. We can look at the lower graph. So overall, 22% benefit of drug versus placebo with Donanemab. And then specifically the first graph with a low to medium tau group, that was 35% and decreased cognitive decline compared to placebo. Now, of course, they also wanted to see the cerebral amyloid levels drop because of their drug. I call these drugs amyloid vacuums. They really clear out the amyloid quickly. Now, a unique feature of the way they did this study that now corresponds to how this is being prescribed in the real world, and it's different than Lecanemab, is that they're in the trial, so everyone was blinded. No one knew if they were getting drug versus placebo, but they would have amyloid PET scans done periodically every 6 months. And so if a person was on the active drug and their amyloid levels normalized on the amyloid PET, they would be switched to placebo in the study. They wouldn't know it though. Everyone was blinded. And so they would continue on placebo for the remainder of that treatment period. And so based on their trial design, almost half of the subjects were able to stop the active drug by 12 months due to normal amyloid levels. And what they found was that cognitive benefits persisted at 76 weeks. So that's like 18 months for active drug group that stopped at 6 months or 12 months. And so now that's transferring to the real world. If your doctor prescribes this drug, Donanemab, they're going to repeat the amyloid PET scan probably at 12 months. And if it's normal levels of amyloid, they will stop the drug, which is different than Lecanemab, which is intended to be continued with maintenance dosing beyond on that time period, even when the amyloid levels have normalized. And there's arguments for that, which I'm happy to go into at the end if people have questions about that. So then you can see the ARIA, that the fluid shifts and the bleeds. This is a little higher than with the Lecanemab for the active drug. So we have 24% for the edema, 25% for microhemorrhages, and then another form of bleed called superficial siderosis at 15%. And then you can see compared to placebo, and then headache and infusion-related reaction. Now, I alluded to this earlier about the low tau group showing more benefit, but what these trials both have shown consistently is that the earlier these treatments are started, in terms of disease burden, the bigger impact it has, the more benefit it has on slowing progression. And so I won't go into all of these, but there's people who are in that low tau group and have mild cognitive impairment. So earlier symptoms have about a 50 to 60% slowing compared to someone who's not on one of these drugs at that 18-month period. So that's really, I would say that's really powerful. Let's shift now to talk about the risks, potential risks and side effects. The common side effect are infusion-related reactions. Now, these reactions are common with any kind of infusion. In the trials, these occurred 9 to 26% of the time, and usually in the first few infusions, most often even with the first infusion. So what is this? So symptoms are flu-like symptoms, nausea, vomiting. They can be increased blood pressure, shortness of breath, and typically mild to moderate in severity. So a patient will go to their infusion center and the nurse is going to watch them very closely, especially with the first few infusions. This can happen during the infusion, or this can even happen after when a person goes home. So they need to be monitored by a family member for several hours. And these are manageable via slowing, stopping, or pausing the infusion, and can be treated symptomatically at the time that it's happening. And also usually patients who've experienced this with one of their first infusions will typically be pre-treated with antihistamines, acetaminophen, or corticosteroids before the subsequent infusions. And so these are usually very manageable. Now let's talk about the more concerning side effect of ARIA. So this is, ARIA stands for amyloid-related imaging abnormality. And this is termed this because as this whole class of drugs, anti-amyloid monoclonal antibodies, was starting to be studied many years ago, it was identified, and unfortunately it was usually in people who were symptomatic, and some people in earlier studies of different drugs died before we really got a better sense of this. This was found, they would have imaging done and they would see these changes on MRI and subsequently call this ARIA. And they saw that there was the E, the edema, or the H for hemorrhage. And often these would occur actually in the same area of the brain. Now, this is not totally understood. It's not completely understood why this happens, but I think it's helpful for patients and families to know that essentially it seems that there can be amyloid kind of surrounding blood vessels in the brain. And as this amyloid is getting really effectively sucked out of the brain, the vessels can become destabilized, and so fluid or blood can leak out. And also there seems to be possibly a neuroinflammatory effect as well of these drugs that can set the stage for these side effects. So you can see pictures here. These are MRI images of the edema. So you see the white here on certain imaging on the T2 flare, and then these different sequences to look for blood. And so these are usually little black areas that you're seeing. Now radiologists have special protocols that they use when you're ordering MRIs for people on these drugs, that they're going to look at these sequences and look very closely to ensure that ARIA isn't present or to quantify it. So symptoms, positively, this is usually asymptomatic. And when symptoms do occur, they're typically sort of vague neurologic symptoms or like headache, confusion, vomiting, visual change, gait disturbance. Rarely seizures can occur. And ARIA occurs early in treatment. And we found that the first 6 months seems to be the time of hypervigilance for this, which makes sense because that's when that amyloid is getting pulled out of the brain so effectively, and it's disrupting the state of things. So it's important that clinicians know about this, but that they also know that we've been studying this for a long time. This is manageable, and it's usually asymptomatic. And over time, when we continue to learn about, so who is at greatest risk of the side effect? It seems that people who have pre-existing vascular amyloid or cerebral amyloid angiopathy, which is when there's that. And these are entities where people have known amyloid around the blood vessels and then tend to have these microhemorrhages in the cortical lobes of the brain. And so we determine that from doing MRIs, and we can see that before people start a study. If they have pre-existing cerebral microhemorrhages, they wouldn't be eligible. Typically, we would say if they have 4 or more at baseline, they shouldn't get these drugs because then they are at higher risk of ARIA. We found that people who are ApoE4 carriers have a higher risk of ARIA, and it really seems to be it's the 4/4s that have a significantly higher risk. If you're a carrier of 1/4, so a 3/4, the risk is slightly higher than if you don't have a 4, but not profoundly higher. And so the ApoE4/4s are the ones that we really have to keep a close eye on. It doesn't mean that it's an absolute contraindication in the US at least. And I personally think it's a conversation to have with each patient and family. And many patients and families will say, okay, I understand the risk and I want to pursue this treatment nonetheless. It also seems that if there's persistently elevated blood pressure, that can increase the risk. So how do we know that this is happening if it's usually asymptomatic? So in the trials, these 2 phase 3 trials that I talked about, and now subsequently with any studies of these drugs, these kinds of drugs, there's a built-in MRI schedule. So they're done at a pre-specified sequence where the risk of ARIA is highest, so that it will be caught, if it's happening, it will be caught when the patient is asymptomatic. And you can see here the Lecanemab schedule and the Donanemab schedule. And then also there's a Medicare registry that Medicare requires that this information is entered in to ensure safety of prescribing and monitoring. Now, if someone is symptomatic, say they develop ARIA in between their MRIs, they call you, or your family member starts having headaches. Suddenly, you'll call the prescriber, the neurologist, and they'll order a safety MRI that's outside of the sequence. And if they say there's ARIA, there's ways that we quantify that, and radiologists will quantify into mild, moderate, or severe. And then we quantify the symptoms into mild, moderate, or severe. And then there's treatment guidelines for what to do with that. So typically, if it's mildly symptomatic and mild on the MRI, meaning the severity on the imaging has to do with how extensive it is in the brain, how many lobes it is in the brain, how many microhemorrhages, for example. And we have specific guidance for that if we're prescribing. And this is also on the package or the prescriber information for each of these drugs. So if it's mild, then we can continue. It's up to the prescriber. But otherwise, when it gets into the moderately symptomatic or moderate on MRI, it should be suspended. And then if it's severe, hopefully it doesn't get to severe, and that's very rare now in the real world, then it may need to be stopped permanently. Now in the trials, as we're learning, there were more, and over time, and especially earlier on with other drugs that were studied, there were more people that got to the severe ARIA states. So we, are so grateful to clinical trial participants who have gone through this and their family members. And then we see that there were 4 deaths in the Lecanemab open label extension that were attributed to the drug, and then 3 deaths during the Donanemab trial attributed to the ARIA. So here's the MRI schedule as per the appropriate use guidelines for Lecanemab and Donanemab. So Lecanemab is a every 2-week dosing IV infusion. And so you can see this is before the, it requires baseline MRI for both before you start, and I'll talk about that in a second. And then before the 5th, 7th, and 14th dose. And for Donanemab, it's before the 2nd, 3rd, and 4th infusion, and then the 7th. And Donanemab is an every 4-week IV infusion. And you can see that, just to point out that Donanemab, you can see in the month 1, month 2, month 3 there, it's a quick titration from 700 milligrams for 3 months to 1400 milligrams. And then the Lecanemab, it's not listed here, but there's no titration. It's just 10 milligrams per kilogram. Now it's exciting that now these drugs have been approved long enough that we're learning more about, so in clinical trials, we have a certain population, right? And it's very controlled, everything. People are being watched really closely. It's not the real world. So when you get out into the real world, it's different, and people are very different and more heterogeneous. And so we're learning from prescribers out there. And this is Dr. David Weissman, who's a neurologist coming out of near Philly. And so he just published this recently where his clinic has prescribed 94 patients Lecanemab, and out of that, there were 7 cases of ARIA-E, 1 of ARIA-H, and 1 with both, and all but 1 resolved. Now, he has this table here. Well, I would just first mention, so you see how much lower this ARIA-E rate is in real life, percent. Now that's an ARIA-H 1%. So that's what's bearing out across the world, frankly, because clinicians in the real world are being very conservative about who they're prescribing these drugs to, because they really want to avoid ARIA. And so I hope patients and families take that to heart, that that's actually, it's looking even safer the way it's being prescribed now. And there's such systems to support close monitoring and really wanting patients and families to feel comfortable with these medications and have access to them. And I'll just point out in this chart here in the middle, the ApoE4 status, you can see that 4/4 versus 3/4. So you can see there were a couple or a few here that had 2 copies of the 4. And so he was able to safely prescribe. And even though they developed ARIA, it's looks like all of those 4/4s, it resolved. So they've continued. And here's another, this was just published actually very recently. And this is at Lecanemab use in a specialty memory clinic. So this is out of WashU in St. Louis for their first 234 patients. So you can see mean age is 74. And then their infusion-related reactions, 37% had infusion-related reactions for Lecanemab. The ARIA rates were 22%. And was typically mild on MRI and or symptomatic, with only 1 to 2% of patients having significant symptoms. And they still recovered well. So very promising. Again, this is, a decent number of patients now that we're getting to learn about. But this is, specifically people who are going to this specialty memory clinic, which isn't most of Americans aren't going to have access to that. 10% of patients discontinued treatment, so that's a pretty good number. Most people stayed on. And then they point out that blood tests were used to identify the amyloid levels in the brain, and it's required to know that the person has elevated amyloid in order to prescribe these. So Medicare did cover these blood tests to confirm amyloid before initiation of lecanemab in 40 patients. So that's a whole other topic conversation, blood biomarkers, if you're keeping up on that, but that's an interesting thing to know. So who's eligible for these medications? I just made this little stepwise algorithm. So you have an older patient coming in with cognitive complaints. They need to get a clinical diagnosis of mild cognitive impairment or mild dementia, and that can be clinically identified in a number of ways through clinical assessment and evaluation and bedside testing. A formal neuropsychological evaluation is always helpful, but not everyone has access to that. So once there's that clinical diagnosis that they're in the right clinical categories for these drugs, then they have to have confirmation of their amyloid pathology. So if we're going to give an anti-amyloid drug, we need to know they have elevated amyloid. Now, historically, we've used cerebrospinal fluid panels or amyloid PET scan. Now, blood biomarkers, as I mentioned, are just starting to be used by some for determination of eligibility. CSF and amyloid PET, there's pros and cons of each. And it often just really ends up depending on the neurologist and what they have access to and are willing and wanting to do. Now, if it turns out a person is amyloid positive, then a prescriber would look at what I'd call the personalized safety and tolerability assessment. So I use the word hardy, like how hardy is this patient and family? Are they up for this commitment to what they're getting into? Is the person healthy enough? How old are they? Are they frail? Like, might they be too frail to take this on? Do they have a lot of comorbidities that are going to put them at risk? Very importantly, do they have a reliable treatment partner? So it's really important to have someone, whether it's a family member or friend, that is aware, understands, in the loop, and helping keep tabs on making sure the MRIs are done for the ARIA surveillance. Because even though the clinic is going to do that, at the end of the day, the patient has cognitive impairment, and we know it will continue to progress to some degree. And so having that treatment partner is so important. Then the ARIA risk assessment, as I mentioned, looking at the baseline MRI to see if the person has any of those findings of pre-existing brain bleed, superficial sclerosis. If they have a lot of cerebrovascular disease in their brain, they wouldn't be eligible. They would be at high risk for ARIA. And then the ApoE genetic testing, as I mentioned, if you're at higher risk of ARIA, it's recommended to get this testing. It's not consistently covered by insurance yet, but I've heard of it being variably covered, and the prescribing, so say neurologist, can much better counsel on, they need the ApoE genetic status to truly counsel on ARIA risk. So if you or your family, you're considering this, what do you need to talk to your healthcare provider about? You really need to understand what are the potential benefits, what are the risks, how is this monitored for safety for ARIA? And that includes not just the schedule of MRI, but who's coordinating these MRIs? Is there a point person in the clinic that you can call if something comes up? Say you're sick and you can't go to your scheduled MRI. Like, what do you need to do to reschedule that? And also the infusions. So that's every 2 weeks or every 4 weeks. Say you have to miss one, say you have some kind of travel happening, you need to understand the infrastructure and support that you have. It's important to have appropriate expectations. This is not a cure. You've got to understand the costs. So I've heard that Medicare covers about 80% of the cost. And it's hard to throw out a number of, what is the overall cost of the drug? Because you also not just have the actual drug, but there's all the MRIs and other visits and other things related to that. There's a definite time commitment. If you are someone who's a big traveler, to decide to go on an every 2-week drug, that may or may not fit into your life plan. And you may say, I'm going to forego the drug because I want to keep doing all this travel I'm doing. You want to understand logistics and you want to understand discontinuation criteria. And so I would make sure to ask the prescriber what will be signs and how will you determine if it's time to stop the drug. So say you went through all that, got the information, talked to your family, you want to go for it. What happens next? So insurance approvals, and then the MRI protocol. You may have to have another MRI if the last one you had was too long ago. You got to have that MRI to make sure we don't have those baseline bleeds and things. Then you want to the clinic, and you will coordinate with the infusion center, and then you'll start your infusions every 2 to 4 weeks. Here are those MRI schedules again. I just wanted to touch on clinical meaningfulness. There's a lot of discourse about, are these drugs really worth it? There's individuals that don't feel that that benefit that they saw that was found on the trial is really actually meaningful in real life. So that's valid, because underneath that, I think about, so, okay, you have this clinical dementia rating scale, but what does that really mean for a specific person in their life? And there's different ways you can look at this, but most people really say, like, I want to keep doing, like, keep my function, maintain my function, like keep doing the things that I want to do, the important things I want to do, the hobbies and the activities. But it's really hard in a clinical trial with so many participants to evaluate within each person what their specific goals are and if they achieved them. And so there's discussion of how to adjust the trial design to better reflect within each person how to determine benefit or not. So it's important. And I guess, so having been in the trials and having been in the real world and seeing the benefit in real life, it helps me feel more confident. But yes, I'm biased. And a lot of the people that feel otherwise haven't met anyone who takes these drugs. One way that this is looked at, so Eli Lilly did this analysis looking at what they call time saved. So over the 76 weeks of this treatment phase, they looked at the people who are on drug versus placebo. How much longer did they maintain where they were at? And it seemed that it was a little over 5 months within that 18 months that they saved. So they stayed stable in their functional level and cognitive level longer, 5 months more than the placebo. So the people that didn't receive the drug. And so you think about, okay, so that's 5 months over 18 months, like, and if someone's on, and then subsequently the next 18 months, if it's another 5 months, you've saved 10 months over 3 years. And if you're 75 years old, like, that could be very meaningful. So we're still finding those, looking into that with more real world data now. If we look at the second bullet here, Donanemab modified titration dosing, you can see that whereas the first schedule, the schedule that we've been using is 700 milligrams for 3 months and then 1400 milligrams, what they did was just shift to first month 350 milligrams, and then second and third, so 350, 700, 1050, and then up to 1400. And there was significant decrease in the ARIA risk. And I apologize for not putting that up there, but it was quite impressive. And especially for those 4-4s, who I think have about, at the normal schedule, close to a 50% chance of ARIA. I think it decreased to like 19%. And I'm sorry, I don't have those numbers, but this has been submitted to the FDA for approval. So we're waiting to hear back. And then and great news for Lecanemab, hopefully. So they have been studying a subcutaneous dosing. That's a weekly dose that people have been taking at home. And it's looking really effective. So we're awaiting FDA approval for that. So both of these we should hear probably in Q3. So what's still unknown? Long-term effects, good and bad. For example, ARIA. So say someone develops ARIA and it's asymptomatic and it resolves. We can't just say, oh, okay, yay, it resolved, because it's like, well, something happened in the brain and we saw these changes on MRI. So we don't truly know, at a like molecular level and at a cellular level, like is that causing some other issue in the brain that we need to be aware of and for the person? We're still learning about who benefits most from these medications. And of note, they're both being studied in that asymptomatic population that has the elevated amyloid but isn't yet symptomatic. So we're waiting to hear probably in a couple years, we'll start hearing those results. And that will be huge if those studies are positive, of course. We're learning still how it affects quality of life over years, and then the role in combination with lifestyle changes. And then I just wanted to mention, this is future proposed combination treatment strategies throughout the Alzheimer's disease severity continuum, where we really know that is the future. Combination treatments, not just targeting the amyloid. And so this is just a proposal by Dr. Jeff Cummings, but I really like to think ahead of the future, like, well, what is this going to be? And so we can start preparing for that. And so you can see the way that these stages are laid out. There's the biomarker negative or biomarker positive. CU means cognitively unimpaired versus impaired. And you can see the different stages going from very mild impairment to MCI, mild, moderate, severe dementia. And so this is saying, I pointed out the amyloid beta removal and avoid reaccumulation. So we can see that that is seeming to be crucial in the biomarker positive, cognitively unimpaired, all the way to the mild dementia. But then after that, that's not helpful, but there are other things that are helpful. And targeting tau, neurofibrillary tangles, is the number 2, and that's important for most of the disease. And then other things like neurodegeneration, inflammation. I'm excited that neuroinflammation, is getting more traction now. Synaptic changes are being targeted. So there's a lot of studies going on, a lot of things happening. Stepping back to one of my main goals is to help patients and families feel equipped, that they can get all the information they need to make a good decision for themselves. So questions to ask: is this aligned with your goals and values? Are you prepared for the commitment of taking these medications? How do you feel about the risks? And do you have a care team, prescribing team that you trust? And not just a prescribing team, radiology and the infusion center. So those are the core groups on the anti-amyloid treatment team. In some, these treatments offer hope but not a cure. They may be right for some, but not all. Stay informed and stay supported. So there's my info again. Feel free to reach out at any time. All right, great. Well, thank you for joining, and please don't hesitate to email me or reach out at any time. Questions about this or other topics that could be helpful to you. Okay, have a great day, everyone.